Ladies and gentlemen, dear friends, it's a great honor to be part of IBUS and to be here today. My name is Giannoulis and I'm a surgeon from the north of Greece. I will present a lecture about anatomy of breast cancer, anatomy of the breast. The breasts are modified sweat glands and specifically function as apocrine glands. They represent significant gender-identifying features which society and the individual connotes as a phenotypically female feature. Anatomically, the entire breast lies between the superficial and deep layers of the superficial pectoral fascia, which is the subcutaneous fat. The latter is contiguous with scarpous fascia of the anterior abdominal wall. They extend vertically from the second to the sixth rib and horizontally from the lateral border of the sternum to the mid-axillary line. Mature adult breasts occupy a prominent position on the anterior chest wall. The average breast measures 10 to 12 centimeters in diameter and it's 5 to 7 centimeters in thickness. So, the breast is roughly hemispherical in shape and sits on the top of the deep pectoral fascia, which in turn encompasses the pectoralis major muscle. Under the lateral part of the breast lie the serratus anterior superiorly and external oblique inferiorly. The clinical significance of the pectoralis major is that its anterior fascia should be removed in a modified radical mastectomy. Pectoralis minor represents a significant landmark for axillary anatomy, and it used to be excised during modified mastectomies. Serratus anterior palsy is responsible for winging of the scapula when there is an injury to the long thoracic nerve of Bell, and latissimus dorsi represents the anterior border of dissection during axillary lymph node clearance and can be used as a myocutaneous flap during breast reconstruction. On a cross-section, we can see the skin, the superficial layer of the superficial fascia, breast parenchyma, the retromammary space, which is important for the plastic surgeons, the pectoral fascia, pectoralis major, pectoralis minor, and the ribs. For descriptive purposes, the breast is divided into 4 quadrants and the central area, and the quadrants are the superior, medial, and lateral, and the inferior, medial, and lateral. The axillary tail of the breast is named after a Scottish surgeon, James Spence, and represents a prolongation along the lower edge of pectoralis major. It may extend to the axilla, occasionally giving rise to a hypertrophic skin fold. It lies over the anterior lymph node group, and it's important because it shouldn't be forgotten during clinical examination, as it sometimes holds cancerous growths. The tissues lying between the deep and superficial layers of the superficial pectoral fascia consist mainly of fat, but additionally of breast parenchyma and connective tissue. The relative amount of natural fat content contributes to the bounce of the breast with movement. As the volume of fat increases, so does the motion of the breasts, but only to the point where the quantity of fat produces such a large mass that it results in drooping pendulous breasts, as we see in elderly and obese ladies. Mounted on each breast is a more deeply pigmented circular area, about 2.5 centimeters in diameter, called the areola. The nipple caps the center of the areola. The dermis of the areola contains radial and circular smooth muscle fibers, which creates a wrinkled appearance when they contract. Several elevated openings may be observed on the periphery of the areola. These are the termini of the ducts of Montgomery glands. The latter are modified sebaceous glands, whose secretions keep the areola lubricated and supple. During pregnancy, these same glands may secrete a milk-like substance. The nipple is composed mostly of collagenous dense connective tissue and contains numerous elastic and smooth muscle fibers. It usually lies above the inframammary crease at level with the fourth rib. The measurement from the nipple to the sternal notch is approximately 21 to 22 centimeters in a young lady with well-developed breasts, and there is an equilateral triangle formed between the nipples and the sternal rods with a side length of approximately 21 centimeters. These measurements are very important for aesthetic reconstruction of the breast after surgery. The breast parenchyma is divided into 15 to 20 segments of glandular units or lobes, which are radial in arrangement and converge to a series of ducts on the nipple. Approximately 5 to 10 major collecting ducts open at the nipple. Each duct drains a segment or lobe of the breast. Each lobe contains 20 to 40 lobules. Each lobule, in turn, consists of between 10 and 100 alveoli. The functional unit of the breast is the lobular unit. This consists of small glands lined by cuboidal and myoepithelial cells surrounded by a vascular stroma. Small interlobular terminal ducts lead to extralobular terminal ducts, which in turn lead to larger collecting ducts and then lead to still larger lactiferous ducts. Thus, the lactiferous ducts drain the entire breast, and before draining into the nipple, these ducts dilate and form lactiferous ampullas or sinuses. Contraction of the myoepithelial cells and the smooth muscle fibers of the areola aids in emptying the lactiferous sinuses from milk. Now, the suspensory ligaments of the breast constitute a significant factor for the maintenance of the structure and shape of the breasts. These dense so-called Cooper's ligaments are particularly prominent at its lower portion, giving rise to the creation of the inframammary fold. They run throughout the breast tissue between the deep fascia and the dermis of the skin, and being somehow lax, they allow for the natural motion or ptosis of the breasts. They relax with age and time, eventually resulting in breast ptosis. The arterial supply of the breast derives mainly from the axillary artery, the internal thoracic artery, via perforating branches to the anteromedial breast. These arise from the second to the fourth anterior intercostal arteries, and especially the second is the largest and supplies the upper part of the breasts, the area of the nipple, and the surrounding tissues. The posterior aspect of the breast is relatively avascular. Venous drainage follows the arterial supply, and small venules converge around the nipple initially to form an anastomotic venous circle, and then they form two sets of veins. The superficial veins drain into internal thoracic and the lower part of the neck, and the deep veins drain into axillary and posterior intercostal veins. The communication between the intercostal veins and the vertebral veins is very important because it's responsible for metastasis of breast cancer cells to the vertebral bodies, the sacrum, and the pelvis. So here you can see both the superficial and the deep aspect of venous return from the breast. The sensory innervation is provided by the third to the sixth intercostal nerves by their anterior and lateral cutaneous branches. The nipple is supplied from the anterior branch of the lateral cutaneous branch of T4. It forms an extensive plexus within the nipple with sensory fibers terminating close to the epithelium as free endings or attached to Meissner corpuscles or Merkel's disc endings, different receptors. These are essential in signaling suckling to the central nervous system. The secretory activities of the breast are largely controlled by ovarian and hypophyseal hormones rather than by efferent motor fibers. The areola has fewer sensory endings. You can see the main cutaneous nerves providing nerve supply to the breast. The lymphatic drainage is very important, obviously, because the breast is essentially an ectodermal structure. Its lymphatic drainage is mostly parallel to the lymph flow of the overlying skin. The lymphatic flow of the breast is of importance because metastatic dissemination occurs primarily by the lymphatic roots. Lymph flows mainly into the axillary lymph nodes, in part to the internal mammary lymph nodes, and in a very small amount to other lymph node groups, such as the supraclavicular, cephalic, deltopectoral, posterior intercostal, subdiaphragmatic, and subperitoneal. The axillary lymph nodes are about 20 to 40, and they're grouped as anterior, posterior, lateral, central, and apical. The apical group is the terminal group situated at the apex of the axilla, just near where the surgeon can feel the ligament of Halsted. Lymphatic drainage of the breast has been studied extensively, in particular for its role in the dissemination of breast cancer. The predominance of lymph drainage of the breast is via the interlobular lymphatic vessels to the subareolar plexus of Sappi. Lymph is directed towards the axillary lymph nodes, and this drainage is parallel to the venous drainage of the breast. Lateral lymphatics course around the edge of the pectoralis major, which is divided in the picture, towards the pectoral lymph nodes. Additional lymphatics course through the pectoral muscles to the apical nodes. From the axillary lymph nodes, lymph drains to the subclavian and supraclavicular lymph nodes. So around the lateral border of pec major to the central and then to the apical lymph nodes. The lateral nodes also drain lymph from the upper limb. The subareolar plexus drains by collecting trunks into the axillary nodes, as we see here, and the pectoral nodes drain most of the breast. The apical nodes receive lymph from the other axillary groups. There is also a retropectoral behind the pectoralis and a transpectoral route of lymph drainage, and also the other directions that we talked about earlier. The internal mammary or parasternal nodes are variable in number, and they're situated along the internal mammary artery and vein. They can be dissected near the junction of the intercostal and internal mammary veins, and their efferents drain into the jugular veins. There is also the interpectoral, also known as Rotter's nodes, which are a few nodes between the pectoralis major and muscle, clinically significant because sometimes they hold metastatic foci and should be removed during axillary surgery. And the supraclavicular and the other nodes drain some lymph directly from the breast. There have been extensive studies on patients with breast cancer that have confirmed what is now common knowledge, that lymph from all quadrants, from all parts of the breast, drains mainly to the axilla. The part of the breast that drains, there is a considerable drainage to the internal mammary group, is the inferior medial quadrant. Now, the axillary lymph node levels are defined according to the surgeon's approach to the axilla during dissection. they represent a significant anatomical landmark which is used for the clinical staging of breast cancer. There are 3 levels of lymph nodes in the axilla. Level 1 nodes are situated lateral to the border of pectoralis minor. Level 2 are situated under pectoralis minor, and level 3 are situated medial to the pectoralis minor up to the apex of the axilla. We can see that in a diagram as well. Finishing, 2 words about sentinel lymph node. The sentinel lymph node is the first node in a regional lymphatic basin that receives lymph from the primary tumor. So the first node that receives the lymph from around the primary is the sentinel node, and it is usually the most lateral of the anterior group of lymph nodes, level 1, as far as breast cancer is concerned. Biopsy of the sentinel node is indicated in patients with clinically node-negative disease, and it's a very important tool in staging and further treatment of breast cancer. Thank you very much.